Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium. And today we have an in-depth interview, an opportunity to learn about a true innovation in healthcare delivery in this country. Uh, I'm joined by Dr. Alan Dobson, who is a family physician who's been a leader in his community and in North Carolina for many years. More details will come out during the conversation. And also by Ken Terry, who is a journalist, healthcare reporter who's worked at Medical Economics for many years, a very skilled interviewer. And I'm going to turn things over now to Ken to go ahead and lead the discussion with Alan Dobson. Thank you.
Thanks, Larry. Alan, I'm very glad to have the opportunity to talk with you about your important innovations in primary care. Let me just start with asking you a little bit about the background of how you came to do this. After you'd been in practice for 15 years and had grown your group in Mount Pleasant, North Carolina, in 1998, you asked the governor of North Carolina to pilot a medical home program in the state. Why did you decide to do this, and what was your involvement?
Well, thanks, Ken. It's great to be here, and thanks, Larry, for asking. I think it started that as a practicing family physician and being active in the North Carolina Academy for Family Physician, we had worked with the Office of Rural Health in North Carolina since I went into practice. In fact, they helped me go into practice in a rural area with a program they call the Carolina Access Program, which is that was started by Jim Bernstein and Torque Wade, who's been a longtime colleague of mine, and where the notion was that we make sure that every Medicaid recipient in North Carolina has a primary care physician. And because we had committed to that and we're working, all the leadership of the academy and all the family physicians were kind of engaged and trying to help the state make sure people had access to care. And so that became the nidus for the discussion of how do we provide better care in the community for our most needy citizens. And it was in that backdrop, happened to be the president of the academy that year, that we started talking about what was next besides just giving patients a primary care doctor.
Okay. What was the original goal of community care of North Carolina, and how did it build on the medical home program?
Well, at the time, our Secretary of Health and Human Services, Dave Bruton, who's a pediatrician, was a big proponent of physicians having a strong voice in management of state programs. And we felt like the best opportunity for us to prove that we could provide better health care was to put decision-making into the hands of those who actually took care of the patients, and built on a strong primary care premise. And so we just said to, in talking to our docs around the state, our pediatricians and family physicians, what do you need to take care of your patients better? And with the notion of, giving our docs a voice, giving them responsibility, but the state coming and saying, but can we give them resources too to do what's needed? And so we came up with this idea of what happens in a region, not a county, not a city, but a region. What if you got all the primary care doctors together in the access care program and created a kind of a little network and got them to partner with their hospital and health department, social services, people that they had relationships with anyway, and take some responsibility for the Medicaid patients in their community? How do we do that? And the state agreed to let us pilot it. that we would bring people together. We gave some grants to get it together. Um, but it was all based on the primary care leadership in those regions that would pull people together. Some of our hospitals were very supportive of this notion, and the state agreed to provide some seed funding to see how this would work. Once you did that and you asked the docs, what do you need? What do you need to actually take better care of patients? Well, they said, well, we need some care management for our needy population, and we need some data. We just need help. And that was the initial pilot to create a community care network, so to speak, in an area.
Okay. Well, Larry told me, or let me go back one step here. In your slides in a 2007 presentation, I was struck by the fact that the CCNC networks were physician-led and the doctors agreed on the practice guidelines. What difference did that make and how did it contribute to the success?
Well, I often back in those days would get asked by people, how do you get the doctors, the primary care doctors, to be so involved in community care? And you're not giving them a bunch of money. There's not, and it was really giving them a voice, giving them resources, and then making them relevant in their communities. So, the key to this is having physician involvement, and because physicians inherently want to do what's right. They want to provide good care for their patients in their communities, or community leaders, and the power of bringing people together around that was really not a heavy lift. But it's the hallmark of the program, and I often get credit for being the founder. But I was one of many physician leaders who came together in those days to start it, and over the decades of community care, it's a series of physician leaders who've made this program really work.
Okay. Well, as you said, the state did provide resources to the doctors. It looks like they got somewhere around $5 per member per month altogether. And Larry said that in a presentation to FMEC, you said that the doctors were told that they could get $10,000 each up front to deliver certain outcomes. And that altogether you invested $10 million of state funds, and the CCNC network produced $300 million in savings. Well, I mean, to what extent do you think that could the doctors have done this without getting some resources to make that feasible in their practices?
Well, it would have been harder. And most of the problem with leading with money, and we really didn't, that money was not put up to give to the doctors. We created not-for-profit networks in the communities, and part of the PMPM money that went to the doctors was the original access, Carolina Access money that they were getting already to help them be medical homes for the patients. The additional money we put in the community was we decided we want to just give money to lots of practices. We asked them to form not-for-profits in the community that we could then fund needed resources so that care managers could be hired, some basic infrastructure. And it was quite a affordable endeavor for the state. It wasn't that much money, but we were going to look and see what investing that a little additional resources to help the primary care doctors would mean to the state. And the early reports in our pilot networks looked really, really promising. Improved the care as defined by the state and then evaluated. And then, as states do, they're going to get a third party to come in and evaluate whether you save money or not. And it really did. And then the state said, well, if this really works, you need to make this statewide. And so our work through the early 2000s was, okay, can we now expand this to make this truly a statewide program? And that's when it was renamed Community Care North Carolina, and it became the hallmark of the state's delivery system for Medicaid.
Right, right. Well, as you know, the more common approach to supporting medical homes, at least in the commercial insurance arena, is to give doctors, a PMPM care management fee and possibly, quality bonuses. But there doesn't seem to be, much attention given to providing the community infrastructure that you're talking about. What is the difference between your approach and this other approach, which doesn't seem to have delivered as many dividends?
Well, I think it has to do with that, no single practice is an island in providing care. Primary care is extremely important. We need to, well fund it and put as much resources as we can into primary care. But from a population health standpoint, caring for the population requires more than just a single primary care office. It requires coordination with hospitals and specialists and other resources in the community. And it's really hard to figure out how to do that by just giving money to a single practice. And so from a state perspective, saying, well, if we could have a network of primary care doctors or an accountable entity, this is pre-accountable care, that we could give money to for things that we could provide some consistency across the state. We'd like to have care managers or care coordinators. We'd like to have some data sharing among practices. We're going to provide certain things in the community to support our primary care physicians. Then it's a matter of accountability. And I think there are examples. I think you're exactly right. The insurance model tends to be more of give money and put some incentives out to doctors and hope that something happens. But I think other models have actually done a great job. Vermont, for instance, has taken it even a further step. We were mainly Medicaid, and there was huge trickle-down effects to other payers and other populations when you support primary care. But Vermont went and did an all-payer model of what we, with community health teams, which was the exact same concept, but an all-payer version of that. And their results have been well documented as well.
Yeah, I know that they've certainly been very successful. Now, I know at one point the state applied for a Medicare waiver for a demonstration project. I think that was around 2007. What happened to that, and are any Medicare patients now being cared for under the CCNC program?
Talking about the Medicare waiver piece that we did.
Yeah.
Well, I think, I mean, we, let me explain that a little bit. So once we got, going back to the history of CCNC, once we became statewide, I got asked to come join the administration as Assistant Secretary of Health, and also was the Medicaid director. And in running my budget, I realized that 2/3 of the patients were all women and children, and we were doing a great job with them. But I still had a huge budget hole, double-digit inflation in the aged, blind, and disabled, and the sickest of patients. So we actually doubled down on community care and really moved the focus to say, can we use the primary care infrastructure and the community care infrastructure to care for the really sick Medicaid patients?
Right.
And the answer was yes. And we started really getting the significant savings you mentioned, the $200 or $300 million net savings a year off those really high cost patients by providing better community coordination. We also had the notion, well, gosh, another part of the really sick patients are dually eligible, Medicare and Medicaid. And Mark McClellan was the CMS administrator at the time, and we went to Mark and said, hey, Mark, we're doing all this work on Medicaid for the dually eligible. What if we found a way to partner with Medicare in a way that we would share the Medicare savings between CMS and the state, and then we would then share it downstream to the practices who helped us do that. And the only authority he had at that time to do a waiver of such a shared savings, that's a common word, it wasn't back in 7 or 8, was through a 646 quality demo. And another state, and we decided to kind of jump onto that to see if we could do it. And quite frankly, I think it was fairly successful. We didn't get any money because basically we didn't figure out how to actually attribute Medicare patients to the pilot, how to get data, some of the key elements that the state had figured out, but doing it with Medicare was not an issue. But I think it really was the first foray for CMS into the notion of shared savings, and in some of the pilots we now call ACOs. But it was one of our first attempts to partner with the federal government on Medicare.
Okay.
And to what you asked the question, yes, now community care, as things have evolved, are doing Med Advantage plans and a lot of other populations other than just Medicaid.
Okay. When you said when you started out, you didn't get any money, what did you mean?
We didn't get any shared savings, mainly because of how the attribution models were set up, and we, our networks didn't know who we were taking care of. Although it was interesting, when the retrospective look at the 646 demo, all the patients who were attributed or assigned through the Medicaid program that were dually eligible, we saved exactly how much money that we were used to savings. But the rest of the Medicare patients, we couldn't track them. We didn't know who they were. So it was it was part of the evaluation learning that Medicare went back and changed their attribution models and really refined it. So we didn't technically get any savings from CMS or get any money. There was money saved. It just wasn't the way the program was set up. We did not receive a check from CMS, but there was a lot of learning that went on.
Right. Well, according to the CCNC website, you also have some, or they have some contracts with commercial payers. Did I read that right?
Yes, I mean, so it wasn't. So if you just think, we've organized the primary care doctors in the state, and to be kind of, broad brush, a lot of them are part of health systems, but there's a whole bunch of physicians who are still independent, along with their FQHCs and rural health clinics and others. And so what we've done is put the independent docs in a large statewide clinically integrated network, ACO, and are allowing the physicians to contract together for value-based contracts. So that, that's where the community care network, or now the community care physician network, has contracts for commercial and Medicare, state employees, and are working together under that, using the same infrastructure to provide good care.
Yeah, so basically these were the forerunners of the ACOs, and now they're in ACO-like contracts with some of these payers.
Right.
Right. Okay. I mean, just generally, as the program evolved, did you begin to see a spillover, from the work you were doing with the Medicaid patients and then later the Medicare patients, some of the Medicare patients, into the larger population of these practices?
Yeah, I think we recognized very early on that, physicians don't look at patients' insurance cards when they see them. I mean, the front desk may, but so as the work we did to improve asthma care, for instance, for Medicaid patients, improve asthma care for Blue Cross patients and all patients in those practices. And so I think from that standpoint, I think that the early community care work with physicians raised the bar for all patients in those practices. And I think you can see that in some of our work, particularly in pediatrics, which the Medicaid population has more significant impact on their practice volumes than maybe an internist or a family physician. But I think we've raised the bar for all healthcare.
So you believe then that CCNC has improved healthcare delivery overall in North Carolina?
I think that's pretty well documented. Yeah, and and I think putting my policy hat and my state hat on. Been away from that a long time, but one of the things that was just one of the biggest benefits, and it's still there today, is that that public-private partnership between the state and an accountable organization that provides reach. Community care was able to pilot things and innovate and see if things worked. And then if they did, bring it to a statewide implementation in a way that was really cost effective and also speedy.
Right.
And the state became very used to using community care to help solve problems and really get out there quickly to try to affect change.
Okay. When did CCNC begin to emphasize social determinants of health, and what approach did it take?
Well, I think it became very obvious when we started doing the aged, blind, and disabled, when I pushed that population and the legislature agreed to provide some additional funding for the program to say, go take care of our neediest populations. When we put the docs to the task of figuring out what do we do about patients who are our neediest, it became very clear that a lot of that was coordinating the social support structures inside communities. Part of the state's response, and when we did that, was, well, we need some care management data systems so that people can share, our care managers, not just working with the docs, but could share among themselves their care management plans. They could communicate better. So one of the things we did is ask all these 14 not-for-profit community care networks to create a shared infrastructure among themselves, which was first the care management system, and then some predictive analytics to do it. And early on, they said, well, gosh, it would be really nice if we had a registry of services that we could push patients in when there was needs. And it got right down to, because it was kept up by our care managers and our local leadership, it was just an access database, but it would say, if you need a ramp built for a patient who doesn't have money, call Bob. he'll do it for the cost of the lumber, and the church will donate the lumber.
Mhm.
It got to that level of care, but it was enabling communities to help take care of their needy citizens, and I think that was really, really important. But that was kind of the early learnings about social determinants,
Yeah.
on the ground with the docs and care managers doing home visits, trying to figure out, how to solve patients' problems.
So you found that the communities were very willing to support this effort.
They did. They were the ones who insisted on it. I mean,
Mhm.
if
Yeah.
you're a doc trying to see a patient, you're out doing a home visit, you're a pharmacist delivering meds to their home, and you realize that they don't have food. You have a care manager trying to find out why they get readmitted constantly. One of my favorite stories is that we, early days of the Innovation Center, we brought that team down and put them in a van, and we took them down to Eastern North Carolina to one of our networks. And one of the care managers who was supposed to talk to the innovations team about what we were doing was late getting there. And she came in and you know, she was saying, "I'm sorry, but I had to go visit this child who had been in the UNC's hospital 4 times. And it turns out that the child lives in a trailer down a dirt road with no power, and they sent the child home on an insulin pump. And and I had to solve that problem, basically, and everyone's mouths flew open. But that's the reality of of
Yeah. Right.
what they were dealing with. And so that's, social determinants is the broad brush of how we aggregate it together and think about it. But this is real primary care and real caring for
Yeah.
people in the community.
Well, I mean, of course, one of the obstacles that a lot of practices face is, that without strong community support, they don't really have the resources or the time in the practices to deal with a lot of these things. I mean, I've talked to doctors up in Vermont who say that that's one of the reasons that they really, appreciate the Vermont Blueprint of Health because those care managers do help them with that, and they hook patients up with community agencies and other resources to address their social determinants. But you found that basically with the community support, this was actually a cost-effective approach for the state.
Yeah, I mean, and I could rely on it as when we ran the Medicaid budget, that if I put $1 in, I could get 2 or 3 back.
Mhm.
So we kept putting more and more on community care shoulders. And as states are required to do, we had repeated external validation of it, through actuaries it's complicated to really show cause and effect in big complex programs like that. But
Right.
clearly, over the years, it kept the cost of care down.
Right.
The growth of the Medicaid program, it saved significant dollars. So it was a hugely effective program, and I think a lot of lessons learned, and a lot of things, as we've pointed out, is that maybe not the real instigator for ACOs, but a lot of our early learnings, were the precursor of ACOs and social determinants and a lot of other things that people started gravitating around.
So what has been the response, the reaction of primary care physicians in these networks over the years? How have they felt that this program has aided them in their caring for patients?
Well, I'm probably not the right one to ask that, but I think um, based on the loyalty and the advocacy of the physicians for community care, and even our hospitals have recognized that this program has really been a benefit for the state for years, and the construct of of those resources in the community to help solve problems. So the physicians have been huge advocates. You know, they were very resistant to managed care coming in because they were afraid it would totally change how we did things. And in the end, actually, it shouldn't, because now community care is the state's converting over to a managed care system. But community care and the physicians have just contracted with all the managed care companies to do exactly what we've done all these years.
Right.
You know, I used to say in the early days of all this, it doesn't matter who pays for Medicaid patients. It's the doctors and the communities have to take care of them. And if we do a good job, it translates to whoever pays the bills.
Right. So basically, the doctors led the way to managed care on their own terms.
Yeah, I think that's a good analogy. You really do have to put, and back to our early thing, is that you need to put the responsibility of and the resources to care for the patients into the hands of those who actually do it.
Yeah, yeah.
And I think that's really the notion of accountable care organizations. Although I think my only criticism, we've made it so complicated that it's an exercise in the accounting of things versus really digging in and putting the resources there that will get you the savings.
Okay. Can you just say a little bit about the impactability scores, which have become a big focus of CCNC over the last several years? You know, how has that moved the ball forward in terms of improving outcomes and reducing costs?
Yeah, I'm really proud of the work that people, once we created this shared services organization, and we were always helping the state do work with their data. But in this unique public-private relationship, we were able to get the claims data and the data from the state and match it with clinical data that we could get from the community and physicians. And as we started focusing on, with the pressure that states were under with budgets, how do we assure we get savings? Where do we put our resources and our people to work? How do we didn't have this endless supply of money from the state. In fact, we didn't get any more money on a PMPM basis to do more. We just got better at doing work with the money we had and applying those resources. So part of the notion was to say, all right, how do we know which patients to touch, when to touch them, what do they need, versus this thing saying everyone gets a home visit post-discharge. Well, clearly not everybody needs a home visit post-discharge, but some people, if they get a home visit, it will mean the difference between them going back in the hospital or not. And so our really smart, Carlos Jackson, Dr. Annette DeBard, when she was with us, some of our smart, researchers and analysts said, well, gosh, if we could take all this wealth of data and go and crunch the numbers, and we could predict which patients we needed to do something and would create an impact, then we can provide them a score, and we can take our resources and really aim them at the people who will make the biggest difference, particularly looking at people being discharged. And then the other group is our really chronically ill patients who, if we did something, would really make a difference in their outcomes and their cost. And that research is just fascinating. I think it's really contributed to the national dialogue of saying, you really need to take your resources and apply it. And our savings increased exponentially when we really started working smarter and applying maximum resources to the people who really, really needed it.
All right, that's a good point.
That's part of a learning health system, right? I mean,
Mm.
And the docs really contributed. This is again, the docs and people taking care of patients, trying to look at the data and figure out how to do a better job.
Mm. All right. So, the groundwork that CCNC laid has been followed, as we mentioned, in the Vermont Blueprint for Health, and I believe in the New York DSRIP program. I also understand that CCNC helped Arkansas and perhaps other states develop their Medicaid programs for high-risk patients. Where do you see this movement going right now? I mean, is it subsumed under the ACO banner, or do you think that there's the states are moving forward with ways to reduce their Medicaid costs, perhaps in line with what CCNC did?
Yeah, it's hard to see the future. I think that there's a couple things that are useful to note. So community care has kind of moved into a ACO-like arrangement, but ACOs tended to be hospital, these large vertically integrated group of providers in a community. What we've done now is taken community care and make it a very large horizontal network of primary care with resources. And so I think one avenue is, I don't see states abandoning the managed care approach to Medicaid. I mean, I think they've generally found, and legislatures have found it too hard to build that state infrastructure. So I don't see that changing. But what I do see changes is some of the managed care companies realizing, wow, if I had a primary care network that was and it was statewide, I've got my patient population already in a relationship. There's already infrastructure there. If I can share that infrastructure with my competitors, we all save money, right?
Yeah.
So I think that's one avenue. And then most of the Medicaid MCOs are not just Medicaid; they're exchange populations, Medicare. And so the utility of having such a network. So it's really a progression of to a notion of a clinically integrated network of ACOs, a network of networks per se, that may be the future for a advanced primary care system where they can share resources, but also provide a larger voice and accountability in a statewide program or than just a single regional ACO.
Yeah, you see some of these state DSRIP programs, like I mentioned, New York's moving in that direction.
I think so. I mean, I think we continue to have to learn, and it's back to, I was on a call yesterday, but on cancer prevention, and I think we need to move kind of backwards to say one of our biggest, issues in healthcare today is we don't have a system, and everyone's going to these vertically integrated models. But if you're trying to take care of population, you really need a horizontal network that's a base layer of what a community needs. And DSRIP's a pretty, New York's an interesting example, because even if you go into the city and the suburbs of the boroughs of New York, they all have little communities, right? But those little communities are all disconnected from a population health standpoint. And so if you say, what does a community need? Well, they need primary care. They need basic pharmacy, i.e. your local professional pharmacist, and they need an EMS system. And you can look in Alaska or any place else that's rural or inner city, and that's the basics of a healthcare system. Then that plugs into something else, But that's the thing that's disjointed right now. And I think there's some lessons to be learned from Community Care of Vermont or any of the other places who've tried this, is that we've got to figure out how to connect those.
Right, right. Okay. Finally, I just want to, ask you, at the end of the day, what are the benefits of a bottom-up approach devised and led by physicians, versus a top-down approach prescribed by health policy experts or health plans or state bureaucracies?
Well, I think this is, this has been inherent for 30 years, is we don't ask the people who in the communities are the people who are actually providing the care what will work. And so in some sense, we've had so many grants and innovations that have been thrown out there, but they haven't gone anywhere, right? Because their model only worked in the area that it was piloted. And so one of the values that community care brought was to give the physicians in the communities who are actually taking care of the patients a voice and a relevance in the discussion of what would work in your community. And from that, innovation really can take place. You have to be flexible, you have to be patient, but you also have to have a very solid mission. And I'm a huge advocate, living in a rural area and practicing for so many years, but also playing in all these spaces, I can see very clearly, and we don't talk about it enough. We talk about what's the difference between the European system and us. We immediately go to insurance, but I don't think it's insurance at all. I think that they actually have a better built out primary care system.
Mm-hmm.
They always have a physician, a community primary care physician that patients can go to. That's their access point, and they're paid, and they're in the community, and guess what? There's always a pharmacy right there too. And our, one of the biggest problems, and we look for everything else but putting intact primary care in communities. I mean, we'll talk about broadband and all this technology and all this stuff, but in the end, we need to be talking to the patients and the people in the communities, what they need, and how to get it to them. And I think I'm also, I just want to say that you can't replace the trusting relationship with a caring profession, healthcare professional in healthcare. There's a lot of stuff that technology and convenience will take care of. But when people get sick, they want somebody they can trust and they can talk to.
Yep. I really think that pretty much sums it up. And I want to thank you for this in-depth discussion and your great insights. I think this is going to help a lot of people on the front lines.
Thanks, I've enjoyed it, and thanks, Larry and Ken. And I'll be glad to, as you can tell, I'll be glad to talk to any about primary care anytime.
Great.
Really appreciate that. And Alan, I want to thank you for the introduction to Charles Rhodes. I look forward to talking to if someone like you describes someone as a real storyteller, they've got to have some really great stories.
He and we do this for our residents, and we'll tell them stories and about from practice, and they're all just like, oh my God, I can't believe that. But it happens if you're in communities, and I used to do that in the early days. I'd go to the medical schools. In fact, I've been keynoted a few, hooding ceremonies at medical schools, and they always ask me to tell stories because there's always a moral and something worth saying about when you tell it in a patient story.
Well, as I think you know, or said to you the other day, I'm collecting these stories. I think they're powerful, and I think it was interesting. This is totally aside from what we have been talking about. I was on a call on Wednesday with a bunch of patient advocacy organizations. I won't name all of their names, but they're national level organizations. And when they were asked by the facilitator of the conversation, what do they think needs to be addressed to have a better healthcare system, they talked about equity. We need more equity. We need more equity. Well, it was interesting. Last night, I was reading some of Barbara Starfield's early work, and she speaks about equity.
Right.
She says when a community has primary care overall in proportion to the subspecialist, you get better equity.
Right.
And I think it's a challenge for family physicians to say to the public, you want equity, you need more of us. It sounds so self-serving, but it's the truth, because the docs in the community build teams, and the teams respond to the needs of their patients in their community.
And you can't replace that. You have to live in the community that you practice, right? And because, I'll just say our group, Charlie, and so who helped raise money for the ambulance station for our community? We did. Who actually gave the land and created the library? We did. I mean, and the leadership, it's not just seeing patients, it's the presence of a physician leader in a community. I haven't seen patients in Mount Pleasant myself in many years, but I still practice medicine. I go to Food Line, and I can't, it takes me 15 minutes just to talk to patients on aisles who will stop, right? But that's part of, the community, part of what you do. And I think it is missing, and we can make healthcare better. The internet and telemedicine ain't gonna fix our basic problem.
Okay.
Great. So I want to thank both of you. I'll bring things to closure here. When this is all done, Ken will have an article or a description of this in print, and I'll be sharing this with people, call it a podcast, extended podcast, so people can listen into it. And I just want to thank you both very much for being involved here today.
Pleasure.
Good to talk to you, Ken. We might want to, I'm sure being with medical economics for so many years, maybe I can pick your brain on some stuff, some thoughts I have to try to push a little bit.
I'd be glad to discuss that with you.
Yeah, I think well, for Larry Smith, I've made the pitch to the Academy is that you guys you're a C6, you have to be politically correct, but you need a mouthpiece that can really just say what, Larry just said. If you really want this to fix this, you got to put and pay primary care in rural areas, right? Just look at the current COVID stuff. Where do you ever hear about independent pharmacists, primary care, all that? All you hear about Walmart, CVS is putting, but we provide 70% of the vaccines every year.
Yeah. Well, as I said, I've written about this for Medscape. MGMA and to a lesser extent the AMA have been, calling on the government to emphasize doctors more in the vaccination effort. But they haven't received too much of a response. And interestingly, for another story I was writing, I interviewed somebody at the North Carolina Department of Health and Human Services the other day, and I asked them, I said, well, to what extent are you getting vaccines out to doctors so they can vaccinate their patients? And he said, oh, we're sending them to the healthcare systems and they distribute them among their doctors. I said, how about the independent practices? He said, well, not really. We're not really dealing with them,
And that's and I'm starting to get pissed off because you know what? In North Carolina, 50% of the patients are still seen by independent doctors.
That's interesting. Very interesting.
And if we weren't trying to be a nice guy, we'd be up there. And I just talked to one of the governor's people and says, you are pissing off all these independent physicians
Mhm.
because, and that was my last article. Health systems take care of 7% of the vaccines during a normal year. 7%.
Mhm.
Health departments, 2%.
Wow.
Pharmacies and physicians do 70%.
Right.
Yeah, we're the last ones to get them. And if you wanted to, so okay, the hospitals have, physician offices. Well, that would get it up to 30%.
Yeah.
So,
Mhm.
but they're missing 3/4 of them. But the
Yeah.
problem is we're not organized because it's too hard for them as administrators to know how to get the money. They can just give it to the hospital and they've got 10 to do,
Right.
which is the reason we did community care,
Mhm.
is that they could just give it to community care and we'd take care of it for them.
Right.
But North Carolina is totally ignoring it because, again, the leadership there right now is someone from Massachusetts, the secretary, and people who don't know how to actually do it. So
Right.
I'm on my
Right.
soapbox.
That would seem like a no-brainer. You've got all these networks around the state. Why not just distribute vaccine through the networks to your
But
independent practices?
yeah, that's another story. I mean, you got
Okay.
Mandy who has really didn't want to deal with community care because it wasn't her invention, and she's kind of wants to get to CMS. And this is my postulation, not to be ugly, but we deal with that every administration that changes, except the one when I went in, which was, but every year we have to reprove ourselves because you're not the other administration's, invention. So out with the old, in with the new. And one reason the community care has worked, we've been successful at least weathering that storm and having some continuity of structure.
Yeah, actually, this is off the record. I was going to ask you during the interview about the effort several years ago by the state legislature to end community care's contract with the state, and I was curious as to why that was defeated.
Well, so the nidus of that was that the docs always resisted managed care
Mm.
by saying, but we have community care, right?
Mhm.
So it set us at
Mhm.
odds. So the managed care companies,
Right.
in a very orchestrated way, said the only way we get North Carolina as the big prize is to discredit community care. So that was one thing.
Mhm.
So the Senate and everybody was trying to do that. And then they got really pissed off because the hospital, they basically thought we were a shield for the hospitals, which they didn't like. And understandable. But they didn't realize that the hospitals were using us as a shield, but we weren't really a shield. And after this thing was all done, and we said, look, if you're going to go managed care, that's fine. Just tell us, just don't blow us up. We'll help it. Anyway, we said, we'll commit to make it a smooth transition. And then we go and contract with all these managed care companies, and the Senate leadership who didn't like us, suddenly I had one of them say, damn, Doc, I didn't realize you were one of us. It's like, yeah, in other words, we represent all the docs in their rural counties, right? Who are their small businesses, and we don't like the hospitals any more than they do. So after the hospitals threw us under the bus, they finally figured out that we weren't really their tool anyway. Anyway, it's a long story, but that was probably the least fun I've had in a 5-year stretch during all that.
I can imagine. Well,
I got it. That's when I said, all right, I've gotten it across. It's going to be fine for the next decade. I've kind of done my duty now. I'll go, stir up trouble some other way. But yeah, there's a lot of good politics and all that. I mean, hospitals tried to blow us up with HIE, and it's just,
Yeah. Well, the Republicans in particular don't like anything that smacks of socialism, so that they want everything to be privatized. And but in fact, your practices were private businesses, so
yeah, we were a public-private thing,
right.
and
Mm.
so I think once we get to managed care, I think we'll be actually fine.
Yeah. Yeah.
And the hospitals took their resources and went home anyway. So there was a splitting of the baby. So half of the community care is now with us, and the other half of our community care infrastructure was taken by the hospitals. So but
Taken by the hospitals as part of their ACOs, or
yeah they so if you looked into it's all money follows the patient to the practice so some of our networks were supported and facilitated by hospitals, i.e. the one around Charlotte, the one the one around Winston-Salem Medical Center. Duke had one of the networks, and they decided, well, I'm just going to take those care managers and my practices and do it myself. And so that's really what's happened.
Okay, but some of the original infrastructure still exists for the independent practice.
All of it does, yeah. I mean, we kept all the good stuff.
Yeah. Okay.
Oh, yeah, we kept all the good stuff.
Okay. Well, if you ever get a chance to read my book, it's one of the main themes of the book is that the big health systems have taken over American healthcare to a large extent, and that they're actually the biggest obstacles to healthcare reform.
Always have been.
Yep.
Well, what's your book again?
It's called Physician-Led Healthcare Reform, A New Approach to Medicare for All, and it's available from the American Association for Physician Leadership.
I'll get it. I would agree with you, Ken. I think the other thing that's a detriment is CMS is doing, right? All this value-based care and all this, putting the providers at risk. I mean, that's all CMS people, right? I've had my boatload of that in North Carolina because we had, the Blue Cross CEO until he had to resign, was from CMS, and we're going to put the physicians at risk. And there are complex payment methodologies. CMMI with 70 pilots out there. I mean, they basically have pushed everyone into these things. What's the evidence that makes any difference? You've got this trend of complicated, overly complicated reimbursement. You can't survive unless you're in these risk models. They've actually made it so you have to be in the risk models, or they're going to cut your fees, so they're driving consolidation and pushing independent docs out. You just keep looking and see it's a self-fulfilling prophecy that you're not going to have primary care in independent practice unless something changes. And there's nothing to say it actually does anything.
Right.
And now you got venture capital throwing in, trying to.
It's a whole other wrinkle.
I think I told you I'm going to do a MedEc column. 2000, Fortune 500, the top 50. How many were in healthcare? About 4 of the top 50. 2020, 50% of the top 10 are in healthcare.
Yep.
And that's based on revenue and profits. And so if you're trying to save the U.S., the public money on healthcare, that's not a good sign.
Yep. Well, it's like some of these people proposing Medicare Advantage for all, right? They like to expand Medicare Advantage from Medicare to, the whole population. And guess what? They haven't saved Medicare any money. Any money they've saved has gone to their own pockets.
The profit, right? Well, so maybe we should talking about primary care for all, and then let everyone else compete.
Well, we should have primary care for all.
Well, but seriously, so what happens if they just mandated a cap rate for primary care that was adequate and equal across all? Because that's really the issue. It's like, so we're going to solve the pandemic, we're going to put gazillion dollars in a community health center, right? So my next little, you know, disruptive thing, I may take community care. I put a bunch of money before I left into a pot for rural health care. I may see if community care will stand up a virtual FQHC lookalike in North Carolina, so we can tap into that, one, money, and two, the reimbursement that's preferential for FQHCs, but let the docs still work in their independent practice. So we'll just have a virtual operations part of it, and see if we can, I'll let you know what that looks like. I've got some colleagues working on a business plan right now, but
I assume what you're talking about has nothing to do with telemedicine. You're talking about
I'm talking about real live practices. I did that when we started the residency program. You know, we actually created a not-for-profit that we had the hospital stand up and put money in. And then we just rolled our clinic operations into that. The physicians still are an independent practice. So we did the residency and the operations there that we ran, but we were able to take advantage of all the federal money and because the hospital sponsored, but it was a standalone not-for-profit. And it did great. And the docs felt like they were in private practice because they were still in their for-profit physician group. They got to decide their salaries. They ran the practice. You know, I was CEO of both, but the hospital loved it because we weren't I mean, we didn't cost them any money. They got all those referrals, and we pumped doctors into the community. But that might be the thought of how you shore up. Then you've got a big voice, right? Because you could do.
Yeah, well, of course, the big problem in underserved areas is that primary care doctors can't really, make a living if a large part of their population is Medicaid. But if you can support them with the kind of infrastructure you have in North Carolina and give them care management fees, then it starts to become financially feasible.
And if you could get the reimbursement FQHCs get, $180 a visit.
They get paid that much?
Yeah, that's the standard rate for FQHC on Medicare is $180.
No, I didn't
regardless
know.
of the right. I mean, so that's the fallacy of this. It's a self-fulfilling prophecy anyway.
Let's talk some more.
Yeah, we'll catch up a little later. Yeah.
Okay. All right.
I'll let you know what this little study shows.
All right.
It'll be interesting.
Yeah.
Thank you both very much.
Thanks.
Take care.